We welcome you to our module Chronic Obstructive Pulmonary Disease, HCC 111 from MRA Tips. This module has been developed specifically for MRA reviewers as a refresher on diagnosis criteria, documentation, and coding of chronic obstructive pulmonary disease. At the end of this module, the learner will be able to define chronic obstructive pulmonary disease, name the diseases that encompass COPD, discuss the criteria and ICD code for the documentation of COPD, review the example of the assessment and plan for the disease, identify the exceptions to keep in mind while coding for chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease or COPD is a broad term that represents a group of chronic lung diseases that cause obstruction of the airways. These diseases include emphysema, chronic bronchitis, and refractory asthma. Long-term exposure to suspended particulate matter or irritating gases, for example cigarette smoke, can cause a person to develop COPD. Air travels down the windpipe and into the lungs through two large tubes. Inside the lungs, these tubes branch off into smaller tubes called bronchioles that form tiny air sacs at their exit. The lungs rely on the elasticity provided by these bronchioles and air sacs. COPD causes them to lose their elasticity, thus preventing the exhaled air from completely getting out of the tubes. Chronic obstructive pulmonary disease is progressive and incurable. The symptoms include shortness of breath, chest tightness, cough, mucus production, and wheezing. People diagnosed with COPD are at a greater risk of developing a heart disease or lung cancer. The criteria for the documentation of chronic obstructive pulmonary disorder include the presence of a spirometry and a post-bronchodilator FEV1, FVC ratio of less than 0.70, which confirms the presence of a persistent airflow limitation or obstructive pattern. A spirometry test assesses how well the lungs work by measuring the amount of air inhaled and exhaled along with its frequency. FEV1 pertains to the forced expiratory volume, or the air exhaled during the first forced breath, while FVC or forced vital capacity is the total amount of air exhaled during the FEV test. The ICD code for COPD, obstructive chronic asthma, is J44.9 and the HCC is 111. Note that solely chest X-ray diagnosis should not be enough to make a final statement. The assessment and plan should address the diagnosis and include two support indicators. Code the patient's smoking status, if noted in the final impression. Let's see an example of a progress note for COPD. Patient name: Richard Davis. Date of service: October 29, 2019. Date of birth: July 7, 1977. Assessment and plan: COPD. Improving. No symptoms. Continue with Spiriva, 2 puffs, 1 cap inhaled QD. Avoid things that irritate the lungs such as perfumes, smoking, and air pollution. Follow up in 1 month. Exception: there are a few exceptions when it comes to the coding of chronic obstructive pulmonary disease. For conditions where a person has both COPD and emphysema, only emphysema should be coded, but when a person has COPD along with exacerbated asthma, both the conditions should be reported. And lastly, when a diagnosis of COPD has been confirmed, the signs and symptoms should not be coded. We have reached the end of our short refresher course on chronic obstructive pulmonary disease. We gave you a short introduction to the disease, identified the criteria and the ICD code for the documentation of the disease, reviewed the assessment and plan, and finally discussed the exceptions which are to be kept in mind while coding for COPD. Thank you for joining us.